Welcome, welcome. We so appreciate you joining us today on this Friday. It's noontime here in DC. We so appreciate you taking the time out to join us for our webinar, Innovative Diagnostics for Women, which is part of our Breaking Barriers in Alzheimer's Disease series. I'm Katie Schubert. I'm president and CEO of the Society for Women's Health Research, and we are a national nonprofit dedicated to advancing women's health through science, policy, and education while promoting research on sex differences to optimize women's health. And we are pleased to be joined today by two fantastic panelists. We have Dr. Chien-Wen Mao, professor of neuropathology at the University of Utah, and Stephanie Monroe, who is vice president and senior advisor for health equity at Us Against Alzheimer's. I'd also like to thank the sponsor of today's event, Eli Lilly and Company, noting that SWHR maintains independence and editorial control over our program development, content, and work products. And for those of you who are active on social media, SWHR will be live tweeting as always during this event, and we invite you to join us and use the hashtag SWHR Talks Alzheimer's on all social media channels. And so with that, at this time, I'd like to introduce SWHR's Chief Science Officer, Dr. Irene Aninye, who is moderating today's event. Irene.
Thank you, Katie, and welcome everyone. Alzheimer's disease is the most common form of dementia among adults ages 65 and older. And of the estimated 6.7 million adults in the United States living with Alzheimer's, almost 2/3 are women. Alzheimer's disease is characterized into three broad phases: preclinical disease, mild cognitive impairment, and dementia. Because there is no cure at any stage, early diagnosis is essential for slowing its progression, planning for long-term management and care, and maintaining quality of life for both patients and their caregivers. SWHR's Breaking Barriers in Alzheimer's Disease series aims to share experiences of women with Alzheimer's disease and highlight the importance of innovative diagnostics and equitable access to them for women and others affected individuals throughout the diagnostic journey. During today's forum, we will discuss impacts of Alzheimer's disease on women's health, including sex disparities in disease burden, mortality, and access to care, advancements in screening and diagnostic tests for Alzheimer's disease, and barriers women experience when accessing these innovations, quality care and coverage. I'll now introduce Dr. Chien-Wen Mao to talk about the value of diagnostic tests to support prevention and early interventions for healthy aging among women. Thanks for joining us, Dr. Mao.
May I share my slides?
Yes.
My slide looks good?
Yes.
Great. Thank you, Katie and Irene, for the invitation. I appreciate the opportunity to talk about innovations in Alzheimer's disease diagnostics on this platform. Outline of this talk. First, overview of sex differences in Alzheimer's disease. Second, advances in screening and diagnostics tests, future innovations. Lastly, sex and gender considerations for developing interventions. Alzheimer's disease was first described by Dr. Alzheimer in 1907, actually in a female patients. Clinical presentation is loss of memory. On gross examination and imaging, we can find hippocampal atrophy. Pathologically, there is plaques and tangles. That's a major pathological changes. On the sections of the brain from Alzheimer's disease, we can see plaques. Those like we call it cigarette burns. We can also see fibrillary tangles in big neurons. Special stains like cell-flavin S can reveal many plaques and tangles in the Alzheimer's disease patient's brain. Those are basically junk and toxic proteins. Prevalence. Alzheimer's disease is recognized as a public health priority by the WHO and is expected to affect 19 million people worldwide by 2050. The condition remains incurable. A larger number of women than men have Alzheimer's disease worldwide, 2-to-1 woman-man ratio. Sex differences in clinical manifestations of AD. Regarding AD-related cognitive impairment, women score more highly than men in verbal text at all ages. Men scores more highly in visual, spatial, and motor coordination tests. Risk of cognitive decline. Cognitive decline is faster in women than men over 1 year and becomes twice as fast over 8 years. Regarding behavior symptoms of AD, men are more likely than women to show apathy, agitation, and abusive and socially inappropriate behavior. Women more often present with depression, emotion, lability, and delusion. Women with AD dementia experience a partial loss of independence earlier than the disease course than men, so spend a greater proportion of their remaining lives with dependence and extensive disabilities. Biomarker patterns in AD. Levels in A-beta measured with PET-based brain imaging and with biochemical analysis of CSF do not differ between the sexes. Brain atrophy, however, is faster in women than in men in MCI. Bluer the color means faster the atrophy. In female, overall, we have a bluer color means faster atrophy. Risk factors for AD. Regarding cerebrovascular and metabolic risk factors, the prevalence of cardiovascular risk factors and cerebrovascular events is higher overall in men than in women at the age of 60 years. This prevalence is equal or even higher among women after menopause or older than 60 years. Conditions related to pregnancy and menopause are female-specific risk factors for AD. Depression and sleep disorders, both risk factors for AD, are also known to be more prevalent in women. Regarding socioeconomic risk factors, in most cultures, a low income and a low level of education are more common among women than men. More commonly, women are the primary informal caregiver. 75% of unpaid caregivers for people with chronic debilitating diseases such as dementia are women. The caregiving burden is associated with lower rate of employment and the increased prevalence of psychological AD risk factors such as sleep disorder and depression in women caregivers compared with men caregivers. Furthermore, compared with men who are caregivers, women caregivers tend to report a higher caregiver burden and greater caregiver-related role conflict, strain, and psychological morbidity. Older women are more likely than older men to live alone, often because of the longer lifespan. Advances in screening and the diagnostic tests, further innovations. Currently, PET scans that track tau and the amyloid can be helpful for AD diagnosis. Here is a normal older adult. There is a minimal tau and the amyloid deposits in the brain. This Alzheimer's disease patient, the tau and the beta amyloid deposits spread through the brain. CSF biomarker can also helpful for AD diagnosis. ATI, A-beta42 total tau index, and p-tau has 0.8 sensitivity and 0.72 specificity for AD diagnosis. This is a recent breakthrough blood phosphorylate tau p-tau217 immunoassay, the first blood test ever approved to help diagnostic Alzheimer's disease. The blood test is much cheaper and convenient than the CSF biomarker and the PET scan. This test proved to be as effective as PET scan and CSF test for diagnosing Alzheimer's disease. It was featured in Time. The test will be made available for doctors pretty soon. p-tau217 blood level is higher in Alzheimer's disease patients than in normal aging population in different cohort. P-tau blood level increase faster in Alzheimer's disease patients than in normal aging in different cohort. Treatment. Cholinesterase inhibitor. In one study, this treatment in the prodromal stages of AD delayed progression from MCI to AD only in women, suggesting a specific benefit of earlier treatment in women. And this medicine, Momentum, is also approved by FDA. Intervention and investigation includes gamma secretase inhibitor, anti-A-beta tau monoclonal antibody. This is exciting breakthrough recently, and the CAR cell therapy. This is intervention and investigation. Anti-A-beta tau monoclonal antibody include lecanemab. It shows dose-dependent amyloid clearance and a reduction in clinical decline in phase 2 trials. It shows chronic benefits observed alongside potential adverse events in phase 3 trials. It received full FDA approval based on its capacity to eliminate toxic brain amyloid. The donanemab, it designated as a breakthrough therapy. In clinical trials, this donanemab was found to slow progression of AD by up to 60% in the earliest symptomatic stage. Sex and gender consideration for developing interventions. Clinical trials are historically biased toward males. Women are frequently excluded for safety reasons due to possible pregnancy, hormonal fluctuations, and contraceptive use. Preclinical studies have perpetuated this bias by primarily using male mice only or mixed sex with insufficient power in either sex, often due to increased costs. Summary. There are sex differences in cognitive and psychiatric symptoms. Women show faster cognitive decline. Levels of beta amyloid measured by PET-based brain imaging and with biochemical analysis of CSF do not differ between sexes. There is sex difference in brain atrophy rates and patterns. In MCI, atrophy is faster in women than men. There are sex differences in the prevalence and the effects of cerebrovascular, metabolic, and socioeconomic risk factors. No data are available on sex differences in the efficacy and safety of drugs used in recently clinical trials for mild to moderate AD. Conclusion, systemic studying and reporting of sex differences in AD symptomatology, biomarkers, progression, risk factors, and treatment response will be crucial for the development and the implementation of precision medicine in AD. I have a good news. Recently, I attended NIH study section. I noticed sex differences in AD is a research focus. So things are changing. That's all I want to talk. Thank you for the patience.
Thank you very much, Dr. Mao. I would like to note that those who are tuned in live can submit questions at any time using the Q&A function in the app, and we will try to address as many as we can during the panel discussion portion of the event. Next, we will have Stephanie Monroe, who will discuss sex and gender disparities in Alzheimer's disease research and care that Dr. Mao had actually teed us up perfectly for, and she'll also talk about opportunities to address these various disparities. Welcome, Stephanie.
Hi there. So is my screen showing?
Yes.
Very good. Okay. Well, welcome myself to your great meeting. I've been looking at the work of this organization for some time and was just so pleased to be invited to participate. Thanks so much for your time and for your patience. So yeah, we've shared a lot, I think, about Alzheimer's disease and what we know with respect to women, which is not a lot, unfortunately. What I'd like to do is just emphasize some of the things that have already been shared by the doctor and overlay what we know with general health equity information and access. And I'm hoping, yes, okay. So women we know are, with so many things, we're at greater risk for Alzheimer's than men. Of the nearly 7 million people who have Alzheimer's in the US, 4 million are women. Almost 2/3 of Americans living with Alzheimer's are women, and 60 women over 60 are more than twice as likely to develop Alzheimer's than they are breast cancer. 65% of women are caregivers of individuals who have Alzheimer's disease. As I said, they're twice as likely to develop breast cancer. And age, though age is the biggest risk factor for Alzheimer's disease, it does not appear that women who live longer than men, that has been the significant impactor for them being more likely to develop Alzheimer's disease. Research does show that zip code, place where you live, where you die, where you work, i.e. social determinants of health, may in fact be a better predictor of a person's likelihood to develop Alzheimer's than one's genetic code. So before we jump to this, our understanding that studies, unfortunately, despite these statistics, are not designed to study sex-based differences. Let me also share some facts about Blacks and Latinos. Blacks are at least twice as likely to develop Alzheimer's as non-Hispanic whites, and Latinos are at least 1.5 times as likely. They are not being diagnosed or not being told of a diagnosis about 40% of the time. So the counts that we have in terms of Blacks and high prevalence, probably much worse than what we understand. And there's a lot of reasons why people with race-based differences aren't getting diagnosed. And one of them, of course, is they think that memory loss is a normal part of aging. In fact, there was a study that just came out a couple of weeks ago that showed that many doctors also believe that memory loss, which is different than forgetfulness, is a normal part of aging. So we have some work to do in terms of making people aware that it's a disease, that it's not normal, that there are some memory lapses that may be normal parts of aging. Those issues, like where you put your keys and things like that, often will come back. But it's very different from forgetting how to turn on a car or forgetting how to go to church every week when that's something that you've routinely done for the last 20 years. And those issues don't come back. And of course, some of the psychological inappropriate behaviors that people begin to see, difficulty in writing checks or writing mortgages a couple of times instead of just one time a month. These are all signs that we look for and that family members should be looking for and being able to get a person assessed early on, and hopefully on one of the novel new medications, or at least being evaluated and watched carefully. We also have the unfortunate fact that the U.S. Prevention Task Force has not recommended assessments of people. At age 65, people are supposed to go through a Welcome to Medicare visit that includes a mental health exam, which could be either the MOCA or the MMSC, if you've heard about those two. Many doctors don't do the full thing. They make up their own, or they don't do it at all, for a variety of reasons. So we've got a lot of work to do to have assessments become more routinized, to encourage doctors to really look at their patients, especially if they've known them for a long time. And yes, it's a subjective diagnosis, unfortunately. With the blood-based biomarkers that was just discussed, we may be able to do a better job, but there are some problems with that as well. So going back to the fact that studies aren't designed to study sex-based differences, we also have hope of knowing that if we did that if we focused NIH on women-focused research, we could add over $930 million to the U.S. economy, which would give us about a 224% return on investment. If we invested an additional $300 million for Alzheimer's disease research for women, it would pay for itself, returning over $930 million in terms of improved health for women. So we also know that this investment, which is not a lot of money, I spent nearly 30 years working on Capitol Hill, and $300 million really from the size of the overall budget and debt is not a lot of money. And if we decided to do that, we could save people, both women and men, for more than 6,000 years with Alzheimer's disease and other related dementias. So we've touched on briefly some of the historic advancements. The Food and Drug Administration has fully approved the first drugs that have shown evidence of slowing down the progression of Alzheimer's disease, not curing it, not halting it, but slowing it down. And one of the challenges that we have, especially when we're looking at African Americans and Latinos, is, again, we are usually later to be diagnosed, if diagnosed at all. So by the time, if you are delaying your diagnosis, you could very quickly, frankly, move from mild cognitive impairment into Alzheimer's disease, and you may not be eligible. So we've got to really encourage people at the earliest signs possible, please get evaluated, both to make sure that it's not a reversible form of dementia. There are medicines that can cause dementia. There are other comorbidities that can cause dementia. Most of these would be reversible, but we want to get to people and rule those things out, and then be able to move people into prolonged, a study, and possibly into clinical research. So we have that problem. We have issues of trust with African Americans and Latinos, and of course the women in those communities as well. We have problems with access. One of the things that we do as the biomarkers are being researched and slowly being rolled out is we require PET scans. PET scans are like $5,000. We've only got about 2,500 PET scanners in the entire United States. Most of them are located in influential areas, not in places where people from these communities typically live. It can get transportation too. So we have not done a good job of building the infrastructure to be ready for these new therapies. So that absolutely needs to happen, both in terms of making sure that doctors are ready for diagnosis and assessments, federally qualified health centers that serve about 20 million patients who are Black and Latino, that is incorporated in as sort of a checkup from the neck up. We've not built the infrastructure in federally qualified health centers to be able to assess individuals who turn 65 or actually before that. Because the other thing that's exciting is that we've learned that with Alzheimer's disease, we can see the pathology, right, begin on a person's brain 20 years before the first symptoms happen. So that means there's an opportunity for us to employ and encourage people to adopt lifestyle changes, food, nutrition, sleep, exercise, these things that we know and we've studied and research tells us can make a difference. And in fact, in Alzheimer's disease, we know that 40% of Alzheimer's could be prevented if we were able to adopt those things that we know can change and be a very significant lifestyle intervention. So we have the time to do that. We need doctors who can talk about that, point people to the right information, and then, of course, communities that are willing to adapt it. So it's going to be really important, again, to get these early diagnoses and assessments to make sure that people who need the drug get the drug as soon as possible to make the most significant change. That's still going to be a big expense. So whether these medications actually become accessible and available to people who need them, with Blacks, again, twice as likely, Latinos 1.5 times as likely as non-Hispanic, as white Americans, it's going to be really important to make sure that we get them to the people who need it the most. So here's my information. Love to chat with you guys. Feel free to contact me offline at smonroe@usagainst-alzheimers.org. And with that, I will turn it back over.
Thank you, Stephanie. And I invite you and Dr. Mao to come back on camera. Again, we invite attendees that are on live to submit questions using the Q&A function in the app. We will try to address as many questions as we can during the remaining 8 to 10 minutes here of the program, but we might be also combining some that have reoccurring themes for broader applicability to the audience. Please note that our conversation today is intended for educational purposes and is not intended or implied to serve as a substitute for medical or professional advice. SWHR does not endorse any particular drugs or products or methodologies. We do encourage all patients and consumers to confirm information and consult with their healthcare provider to determine individual needs. And so to open this conversation, I would like to start with reiterating expectations, because we talk about age and Alzheimer's, and there's a bit of a concern with forgetfulness, and we've even touched on menopause, and we know that brain fog is associated as a symptom of with menopause. And so, changes in what can we say to changes in cognitive function as we age that is different from signs of dementia or Alzheimer's disease. And so, because they're often conflated or thought to go hand in hand. And so I just wanted to be able to clarify that difference.
So I'll just jump in, I guess, and say, again, we've not done a good job of studying sex differences. Or if studied, reporting out large enough subgroup data that we can make an analysis. So we're not yet, although we think we're going to be moving in that direction, studying the impact of menopause, impact of hormonal changes, impact of pregnancy and other things on women in particular. We have to do that. And I think we're making a public policy push that this is something we need absolutely to understand, because the interventions are going to be different for men and for women, and the timing, right? We know amyloid. We know when we see it. We don't know if women develop amyloid faster than men, earlier in the lifespan than men, because the data needs to be released. We need data common so that we can really understand what's happening with women. And we certainly don't study stress. And if women are caregivers to that rate, we know that there's a lot of stress. So, there are opportunities for us to do this, and we have to really insist that the studies have enough of a cohort size. We don't have the problem with women being excluded from trials per se, but Black and Latino women are absolutely excluded from trials because of comorbidities, because of things like, if you have diabetes, you can't participate in these trials, right? If you have a liver function test, which Blacks often have a higher liver function than others, you're going to be excluded from these trials. So getting into the trial itself is a challenge. If you've had breast cancer, sometimes you'll be excluded from the trial because of a comorbidity that you had, because the goal is to get as pure of a sample as you can to show the optimal success of this drug performing in healthy communities, and then send it into the sickest communities and report adverse outcomes. At that point, we really got to do better.
And Dr. Mao, what are your thoughts if you could say, as we're talking about these studies and these trials and you're, in this space and doing the research and the clinical approach, if you could kind of step on your Alzheimer's research soapbox for a bit, what area do you think needs more attention as far as brain health and aging with women that is not particularly getting enough attention and study?
There are so many factors contribute to the etiology of Alzheimer's disease. It's hard to point out which area is more crucial. Just by my recent experience at NIH study section, the causes, different etiology from in sex differences, actually, I think on all aspects need to pay attention, because the etiology, the treatment, everything show sex differences. By the way, I have a comments on the questions from the Q&A. I'm impressed by the highly intelligence of the audience. I try to apply as much as possible, but some answer that really I don't know. Mhm. Yeah.
No, and that makes sense. We have a very diverse audience, and we're glad everybody's revving up in this Q&A, and so we're really glad that this is a topic of wide concern, and so we're glad that we're here to be able to address some of these areas. And so maybe to the screening age, we talk about diagnostics. You mentioned there's blood tests. We're looking at innovative tests, and Stephanie, you talked about access to various things. There's so many varied recommendations when it comes for screening, the starting age, how frequent. And so how do you think this might affect insurance coverage for women with these ages? And so what can you say for women to be able to advocate for themselves to pursue a diagnosis or to access these various treatments?
That's a wonderful question. About there is I believe some still the diagnosis screening test is not hasn't available yet, although there are exciting breakthrough, and insurance is a major concern. Is a major concern, and we. The association, we should promote some policy implementation.
So let me add this in terms of from a racial and ethnic perspective. We are absolutely all thrilled with the innovations and the new innovations coming down the pipeline in terms of the biomarkers, but they too have to be studied on populations. And typical in America, Blacks and Latinos represent 3% of clinical trials participants. 97% of clinical trials participants are white men of European descent. So if you look at that,
I can add some data. I have been working in the brain bank of Northwestern ADC Center. For more than 1,000 brains are the total brains we have. Most of them are from Caucasian. We only have like less than 5 brains from African American. The difference is striking, for enrollment, retention, the African American patient in the trial, it is a problem.
Big problem. And so the biomarkers that are rolling out haven't been, for the most part, I mean, there's some and I won't mention specific studies that have done a pretty good job of hitting the representation. But that needs to be a question that we ask, upon whom were these innovations tested, to make sure that the data is generalizable and that it can be applied across populations.
And that's something that I know we echo. It's extremely important with Alzheimer's. It's important across all clinical trials. And so SWHRs, that's one of the areas that we have definitely been heralding over the years: inclusion of women in clinical trials, inclusion of, in this case, not so much but pregnant and lactating women in clinical trials, and making sure we also have very diverse populations that can help us to get whatever care is developed, the interventions, the diagnostics, the treatment options, that they are reflective and they are appropriate for diverse audiences, so that the most vulnerable are able to access and get appropriate treatment. And we know, or we have a better idea of what's going to happen and what those outcomes can be, so we can optimize health for all individuals. And so I know we're coming close to time. And so before we wrap up, I want to ask one last question. As I mentioned, we have a diverse audience of patients and general audiences that come, as well as researchers. We have healthcare providers, industry and policymakers that tune into our events. And so what is one takeaway that each one of you would recommend for our viewers to help them support research and screening for Alzheimer's disease in women? And so Dr. Mal, we'll start with you. If you just have that takeaway that you'd like to leave folks with, and then Stephanie will end with you.
We talk about the issue of women, especially older women. There is no, they probably have no people have the make the consent and keep the enrollment. We need some power to help those women, especially older women, enrollment in all the trials for for diagnosis and the clinical trial. They need some help. Yeah, that's my answer. And by the way, I'm so sorry I couldn't answer. There are still 10 open questions. Feel free to reach out to me over email. I'm happy to answer as best as I can.
Yes. Stephanie?
Yeah, we've got to make sure that policymakers and others understand it's not acceptable, that we're not asking these hard questions, and be armed with data in terms of, we're either going to pay now or pay later, right? Women are half of this population. We've got to make sure that we are getting access to the right treatments. Let me do a quick plug, shameless, but it's free. This is a free product for people who aren't being assessed or want to get an idea of themselves where they are. You can go to mybrainguide.org. It's free. It's a validated tool, English and Spanish. It's written with cultural sensitivity. You can get an idea of how you are doing in comparison with your peers, and it'll give you a printout that you can take to your doctor to spark that conversation. Because people often wonder, how do I even tell this? But the doctors are willing to look at the sheet that says, this is how you performed, this is where you didn't perform as well. It's free, mybrain.guide.org.
Great. Thank you so much, Chin-Wen and Stephanie, for sharing your time, your expertise, and your insight, and to Eli Lilly and Company for their support of SWHR's Alzheimer's disease program. We're dropping in the chat for those that are online. Again, that's mybrainguide.org, the resource that Stephanie was just mentioning. SWHR will continue the conversation. Hashtag SWHR Talks Alzheimer's in our work to promote research to better understand, diagnose, and treat Alzheimer's disease in women. Our next event in this Breaking Barriers in Alzheimer's Disease webinar series will be a congressional briefing in September in recognition of Healthy Aging Month and World Alzheimer's Day. Alzheimer's disease is also one of the focus areas of SWHR's Women's Health Dashboard. Through this platform, you can explore the latest national and state data on diseases and health conditions that have significant impacts on women's health across the lifespan, including public health data, research investment and progress, health insurance coverage, and relevant policy implications and actions. You can learn more about SWHR's advocacy work and future plans in the Alzheimer's disease space through our call to action report, Advancing Care for Women with Alzheimer's Disease, and Policy Agenda, Breaking Down the Burden of Alzheimer's Disease for Women. And as always, we invite everyone to connect with SWHR on our website, www.swhr.org, as well as on social media to register for future events, download women's health resources, and sign up for our newsletter. We will be sending out an email with a recording of today's webinar to all registrants, as well as post the recording on the event's webpage for future viewing. So please be on the lookout for that and feel free to share with others as we continue the conversation. #SWHR Talks Alzheimer's. Thank you for joining us.